learn about what we do and how we interact with our own patients, but then more importantly, how can we work more collaboratively, interprofessionally with our patients to provide best outcomes. And clearly all the data supports that, and we just got to figure out ways to be more efficient and effective to get to that place, to be able to do that. So I'm thankful for the opportunity to come and share some information with you guys today. And we're going to focus primarily on imaging as it relates to musculoskeletal aspects of patient care. So obviously imaging, there's a million things that can be covered, and we may deviate off just a little bit, but for the most part, we're going to stay within the musculoskeletal world. When we first put this together, I asked one of my colleagues to join me to put this presentation together, and that's Dr. Nada Salvatore, who's one of the PTs back at Brooks as well. And she wasn't able to join me today for this presentation, but I want to make sure that I acknowledged her contributions to the presentation in terms of putting it together and getting it to this point. So the modalities that we're going to focus on today are listed here. Again, there's other modalities that exist. These are just the ones that we'll talk about. I think it's important to recognize the relative costs within the healthcare system that, there's more than one way of skinning a cat. And so there's times when you really need to get a CT done because that's the critical modality to get the image that you need. But there's other times where something a little bit less expensive might give you the same outcome. And we need to be aware of those, that we're not, hitting a trigger every single time and saying CT, when probably we could have gotten away with a plain film or maybe even an ultrasound or something like that. Because that is, in the real world, that is a consideration, in terms of the cost and expense to patients, to the payers, and all of that. The payers aren't altruistic companies, not to throw them under the bus, but they're for-profit companies, and they just pass on expenses. So we're just hurting ourselves anytime we push something out there that where we're spending a little bit more money on something. We're not just hurting the company, we're really hurting ourselves. So we'll talk about, we're going to start off primarily talking about the musculoskeletal radiology and lots of different modalities we can use within that. Of course, the most common one is plain film imaging, and the story that I like to tell about that is that obviously Wilhelm Röntgen, first identified the X-ray, and German physicist. But in the United States, Frank Austin was a physicist at Dartmouth, and as that information came out about what Röntgen had been doing, lots of scientists all over the world were experimenting with it. And what Frank Austin did, he was the first one who actually demonstrated that you could take a plain film and see the inside of your skeletal structure with these new tubes that they had identified, exuding these rays. And then the other thing he did was he was the first one to actually utilize it for a medical application. So it was his brother was a physician, and he had a patient, a young boy, adolescent boy, who's fell down, hurt his wrist, and they put it in there, and took the what now we call plain film imaging, and they took a film of it, and they saw that it was actually fractured. And that was the first time anybody had actually seen a fractured bone without going inside and looking at it, without entering through the skin. So that's what Frank Austin's contribution is. These are, relatively easy to do, and we'll come back and talk more about this. I think you guys are familiar with this stuff. If I'm either doing it too fast, too slow, whatever it is, I can speed up, slow down, I can go into more depth, I can go into less depth. Just you tell me what you need, and I'm happy to accommodate your learning. I'm not here to share my spiel with you. I'm here to help you learn. So if whatever it takes for you guys to learn, that's what I'm here to do. So the X-rays are a short wave form of electromagnetic radiation. Things like bone, stuff with high density is going to absorb it. even other organs, tissues will absorb energy, but not as much as bone. So you can see on a plain film, you can see the bone pretty well, but then you can see other organs and other tissues. You can even see swelling in there, but it's not showing up as clear because it doesn't have that same density. So again, besides musculoskeletal, you have utilization for looking at people's abdomens, looking at their chest. You can see that things just don't look right there, huh? There's just too much stuff, right? And then there's extra stuff that's not supposed to be there. Okay, so it's not diagnostic per se in many cases, what's going on in there, what the stuff is, but it tells you that's a first step in the right direction, that something's not right. Now maybe I need to consider another modality. Within plain film imaging, we use the ABCs. A, talking about alignment. B is the density. C is the cartilage spaces, which is one of the classic characteristics of arthritis. We look at any joint, and you look for the joint space, particularly something like the knee, and you can see if there's bone on bone, then there's pieces missing, meaning the cartilage, because it should look under normal like the two bones are just floating in space, and if there's bone on bone, then that the cartilage is missing, which is part of the criteria making the diagnosis of arthritis. And then the S is looking at soft tissues, because again, it's not definitive, it's not diagnostic for most soft tissue disorders, but you can use it to see if something's correct or not correct, or if it's present or not there. So in terms of the alignment, whenever we're looking at a plain film, we always want to look, there's an algorithm, there's a process that we go through, and the first thing we look at is just the alignment of the structures. Is everything in the right place? Okay, if we're looking at a peripheral structure, is there a good alignment? Is there a displacement? Okay, and then after that, we're looking for, even if there's alignment, is there fractures, or is there extra parts that shouldn't be there, or emptiness? We're looking for, because it could be a malignant tumor there. So, and the tumor itself might not show up really strongly, but the empty space shows up. We're looking for the relative density, and if somebody shows up with poor density on a plain film, then they've already gone pretty deep into osteopenia, okay, well on their way to osteoporosis. So if somebody could be probably 50% down and still not show up necessarily. So this isn't the best way of determining, somebody's relative bone density. But what you do know is if it's showing up and there's poor bone density, then they're already on a bad path. We talked about this looking at the over here, nice clear joint space. So that's telling you that there's cartilage in between those two bones that are separating them, versus over here, bone on bone. So there's clearly no cartilage in between those two structures, which is, like I said, one of the criteria for arthritis. The other thing that you look for on this imaging is to help tell you what the relative maturity of the individual is, skeletal maturity. And so you're looking for the epiphyseal growth plates. And so if you see open plates, then you know that you're talking about somebody who's skeletally immature. All right, so typically, for females, 16 to 18, and for males between 18, it's a range, but 18, give or take a year or two. And then again, you can look at soft tissue. So you don't necessarily know what that big mass is, but it's not supposed to be there at the tip of the elbow, right? So it's probably an olecranon bursitis, but you don't know 100%, by just taking the plain film. You can look at things like for the temporal mandibular joint, if there's displacement of the disc, and then again, just in this individual, just the amount of subcutaneous swelling. It's so so thick and dense that it's showing up on the plain films. So lots of advantages to the plain films. They're pretty much available anywhere. I mean, you could go, I mean, even some of those care spots, you know, you can go and get a plain film done, all right? And you think about the expense relatively, they're at the low end of the continuum from the, you know, looking at the all of the modalities combined. It doesn't really require a lot of advanced training. I mean, clearly the radiology tech needs to have some level of training, but the training for that versus nuclear medicine is very different. And these are very easily performed. You can do it quickly. You can do it pretty much anywhere. They're portable. You can even take them. You know, you've seen them go into the surgical suites with them. You know, and physicians, the surgeons will look for the position, the alignment, the integrity of the fixation, you know, before they close up all the way, just to make sure that they got it right and there's not something that's not really matching the way it's supposed to. So they can bring the plain film image fluoroscope in there. They can, you know, look at them in full extension, take a shot. They can look at them in, say, a knee, doing a total knee replacement. They could, you know, look at them in full extension, look for the alignment there, and then put them in full flexion, see how much they got, and see for the alignment there. And that gives them a good indication, yeah, we got good fixation here. We're okay, we're ready to close. You do expose people to ionizing radiation, which is not a good thing, okay? Too much of that and you create, you know, bad stuff happens. So we do want to be responsible about that. It's not as sensitive as some of the other modalities. We talked about that with CAT scans. We'll continue talking about that later on, that the CAT scan in some parts of the body where it really is critical to get it right, like say the upper cervical spine, a lot of times you start off with a plain film, and if you're getting some funny subjective complaints or your objective signs are a little squirrely, then the next step is to go ahead and jump in and get a CAT scan, because it's going to be a lot more sensitive and it may pick up fractures that the plain film didn't pick up. It's not good at soft tissues and the small fractures that I was talking about, and requires patient cooperation. I mean, the patient has to lie still. So if you're talking about doing this with a youth or somebody who's, you know, intoxicated or, you know, under the, you know, having a problem, you know, with something that they just took, you know, the Saturday night problem you see in the emergency rooms, you know, that makes it challenging to take a plain film. Okay, so there are limitations that you do need the patient to cooperate with this, because if they're not sitting still, and that's really true of all the modalities, so that's not unique to this one. So what do you guys see abnormal here? Yeah, you've got a little bit of fluid buildup here, huh? So again, non-musculoskeletal, but I just wanted to throw that in there just to demonstrate that there is a really good application for this outside of the musculoskeletal world. So the next one to move into is fluoroscopy, and it's really just it's a plain film image at a lower dose, and the nice thing is, but it's because it's at a lower dose because it's utilized for a longer period of time. So sometimes fluoroscopies are used to assess movement, so you can actually, you know, put somebody in a unit and have them move, and so you can measure the amount of movement that's taking place and look at how each segment of the spine, each vertebra, moves relative to the other one. You can do it for different types of testing, you know, upper GI, lower GI testing, where you're sticking something in the top or the bottom and you're watching how it traverses through the body. So, you know, fluoroscope has lots of really good utility to it, and it gives you that information in real time. So I mean, literally, as you know, somebody's drinking, you know, the barium stuff, I mean, you're tracking it and you can see where it's happening at that moment in time, you know, instantaneously what's happening. So again, this is something that's frequently, you know, they'll take it into the surgical suite with them, and they can, you know, we talked about looking at movement, you know, maybe of a hip or a knee or some other joint. A lot of the uses for this are non-musculoskeletal, okay? Looking at all the different ways of tracking, fluid as it runs through the body, through, we talked about through the upper GI, lower GI, through contrast, utilizations of contrast injected into the arterial, venous systems. And so, I mean, those are really good utilities of this thing. But again, it does have the musculoskeletal component as well. The guy who invented, I'm sure you guys have heard of facet joint injections, the cervical or lumbar, where they go in and inject facet joints and do that sometimes as a diagnostic test to assess if the facet joint is involved as part of the pain generator. But they'll also do it they'll inject steroids, to help decrease pain and help things to settle down if it's a really irritated joint, if it's a reactive joint. And the guy who invented that is he's Charlie April, and he's a musculoskeletal interventional radiologist in New Orleans, and I practiced there for 24 years. And so him and I developed a really good, close relationship, and primarily because of our mutual love for sushi. And so I love the story he would tell me that when he first started doing this, and he would go around the world teaching other people how to do it, he wouldn't trust anybody else to do it at first. And so he would be in this classroom, in like more of a kind of a surgical suite, and he'd have the fluoroscopy, and he'd have a screen up on the wall, and he'd position himself, make sure the table was positioned right, and that he was positioned right, because he would take the needle and he would stick himself and show everybody how to do it on himself. Okay. So anyway, I thought that's a funny story. So advantages, again, it's fairly widely available. You go to any, system hospital. I mean, even some of the smaller hospitals, rural hospitals, and they'll have the opportunity and the ability to do this. It's not very expensive. Again, relative to the scale, the continuum, it's very functional and demonstrates really good anatomy. In terms of the, how you can measure the whether it's the ionizing stuff going through the system or the stuff that we swallow or the barium stuff. And you don't need sedation for it, okay? Which, I don't know if I was Charlie April, I might have wanted some sedation, but it does require that you either ingest or inject something. And that's always, there's always the possibility for complications related to an allergic response, okay? And we always, you ask people, are you allergic to this stuff? And they say no, but it's because they've never had it before, so they haven't had an allergic response because they've never had it, okay? So, again, you need patients to cooperate. If they're flailing around, you're not going to get a good view necessarily, and less so than than obviously the plain films. And it takes a lot more time. It's the plain films, you just get in, bam, you shoot it, and it's done. This fluoroscopy, I mean, you got to wait. You got to let the stuff really traverse through for you to get the full picture of what you want. So it's not horrible. We're not talking about 2 hours, but it could take 15 minutes, 30 minutes, something like that. So the next one is arthrograms. Have you guys, are you familiar with arthrograms at all? It's pretty much used for joints. It's less utilized today than it used to be because of the MRI. Today, the MRI has not completely replaced the arthrogram, because there's still some physicians that believe that they can get a better look, and they're right. So it's not just their opinion. It's I'll tell you a little bit more about it. It's you're taking a plain film, and again, it's much like the fluoroscopy, where you inject some kind of tracing dye into a closed system, and then you're looking to see if it leaks out or how it traverses through. So, say in the shoulder, if you inject this dye in a certain place, you'd expect to see it go a certain direction, assuming everything's intact, assuming that the supraspinatus tendon is still attached, that it's not torn. If you see it taking a different path, and it's traversing through where that tendon is supposed to be, then that's a really good indicator that the tendon is torn.
okay? Or maybe even partially torn. The reason that's better than MRI is that sometimes, depending on the patient, depending on the strength of the image and it just doesn't always show up so well on MRIs, okay? As much as we want to believe that the MRI is absolute and it's diagnostic 100% of the time and it always shows us what we want it to show us, the reality is that the magnets are always getting stronger, the software is always getting better, and so the imaging is getting better over time. So it's better today than it was 3 years ago, and in 3 years it's going to be a lot better than it is today. The reality is right now we get some false images. We don't get, it's not black and white. It doesn't show us 100% of exactly the anatomy inside, okay? Because there's a lot of finagling that goes on within the software that to kind of give you an image that its perception of the image is, which may not be 100% related to the true anatomy, okay? So that's why the orthogram is still utilized by many physicians to help identify some of these tears and other problems like that. So there is a contrast used. This is a picture of a knee, and again, it's just showing how the contrast, goes through the system, and if it's filling up bursa, or if it's leaking outside of the synovium lining or outside the capsule itself, and so that's what we're looking for with the orthograms. It's really looking to see is they're intact. Because so here's another example. You could have somebody with a torn capsule, but they're not displaced. Think about like a fracture, non-displaced fracture, and you're looking at it, and the two ends are torn here, but they're still connected, and seeing that on the film may not really show up very clearly. If you stick some contrast in there, and then the contrast starts leaking out, then it's really clear that there's something going on in there. Okay, so that's the advantage of the orthogram over something like an MRI. In today's world, I'll tell you that a lot of times they'll do the MRs first, and if their gut is that there's something like a torn tendon or a torn capsule, and the MR doesn't show it, then they'll follow up with the orthogram to give them that second look. Yes, sir.
Good question. Is the orthogram more expensive than the MRI?
No, it's cheaper. So, yeah.
So why the reversal?
Because they've become so dependent on MRs. It's just the game. It's just the habit that people have fallen into. They've become some. And I'll say this, and it'll come across in a negative way, and I kind of mean it in a provocative negative way, but it's probably the truth that many practitioners become seduced by the technology, and they just automatically go to these high-end things first. It's like shoot first, ask questions later. Okay, that's the behavior of some practitioners. Okay, so it's just the reality.
Would it maybe then also be preferable for the patient though, because they don't have to have anything injected into them?
Yeah, if there's a concern about potentially having a reaction to that.
Well, I would just be nervous if it was me personally having something injected into my knee as opposed to just sitting in an MRI machine taking a nap or something,
Yeah, right. Yeah. I think that's a good point. Yes, sir.
And it sounds also like there's dexterity involved.
Is what?
Dexterity, like the precision of your injection.
Practitioner has to have.
The direction.
Oh, absolutely, yeah. So you're correct. I agree that there is but it's not rocket scientist. But you're definitely correct that there is some nuances to hitting it in the right spot. So yeah. So, okay, good. Thanks. I would prefer to have questions, so please don't hesitate to ask questions or even enter into a discussion if you want to talk about something. I'm really happy to do that. So again, we're looking at a wrist now. They inject it, and then they start noticing, oops, we lost containment here. That's not supposed to be coming out down here. All right, so that clearly demonstrates a tear of the capsule of the wrist joint.
And then same thing, and these are an isolated shot, so it's not really doing it justice. It's really, the value comes in as you're watching it in real time, as you're watching the joint spaces and the cavities fill. But again, we're looking at it like in this case, this is really clear that, this fluid down here that's not supposed to be there. Okay, we've lost containment of the contrast, all right? Versus in this one, it's not so bad, but this is just probably the sequence that it went in, particularly right here. This shouldn't be here if there was a supraspinatus tendon present there, okay? And this is demonstrating that there's laxity in the capsule, that there's probably a anterior inferior dislocation at some point that caused some stretching or ripping of the capsule. That was nada. So we're going to move on to the MR now, and the story of this is pretty interesting. The initial name of it was the Indomitable back in 1977, and this is the inventor, and I apologize, I can't remember his name. And there were multiple guys working on this type of unit simultaneously, and there's some debate like which one was actually the first to do it. And I wish, I apologize, I can't remember his name. It might come back to me. But this poor guy is his grad student, and it turns out, he's not a big guy, but he was too big based on the unit itself and how it was built. He was too big to go in there. So the poor grad student ended up being the first one put into this machine that nobody had ever done before, and not knowing, like, my eyeball's going to pop out or what's going to happen, and all the metal for the next 3 blocks are all going to come in and collapse the building, and so all of these what ifs, had no idea, and I'm sure these guys ran and took cover in someplace in the control room, and they left the grad student to try and figure it out. And so that was the beginning of the, his name's right there, God. So here's the deal. Yesterday was my first day back in the office. I was out for 3 weeks. I had 2 meetings. I was up in Boston for 11 days for a professional conference, and then I was in South Africa for 11 days for a conference. And so I've literally been out of the office. This is my 2nd day back, and I don't really believe in jet lag, but if there is a such thing as jet lag, then I think maybe I might have a little touch of it. So anyway, let's start the Raymond Damadian. Okay. Thanks for being gracious and not pointing that out. Oh, God help me. So I think you guys are all familiar with the MR, that it's non-invasive. It's really, really nice at visualizing soft tissues. You can also see bone pretty well, so it is utilized for bone as well. But it's where its claim to fame is for soft tissue. And so at some point, if you had a choice, I have this patient, and am I going to use CT or MR? The options become fairly clear. What do I want to see? What kind of tissue do I really want to image and look at? If I want to look at more bone, then you're going to go with CT. If you're going to look at soft tissues, then you're going to go with MR. Okay. The stuff that they're doing now with both the MRs and the CTs is just amazing. The 3D modeling that they'll do, where they can stick somebody in a machine, and then you bring it up on the screen, on the computer screen, and say, for example, the heart, and you can get the picture of the heart. I wish I brought my CD. I just had a CT angiogram of my heart done recently, and it's amazing to see how they do it. They could, at any place, any one of the arterial vessels, they can slice it open and look and see what does the lumen look like, if there's any plaque in there. And then the other thing they do, it's amazing. I thought it was really cool. It looked like a ride at Disney.
they can go in the end of the blood vessel and then just traverse through the entire vessel. And, you know, along the way, you're looking to see, you can see, is there any plaque, is there any stuff in there? And you just go through the whole, you know, vessel and all the way up to the chambers of the heart. It's just unbelievable. Just by the way, mine are pristine, zero. I had zero plaque or anything. I was on the way home. I had to have this done in Tampa because it's a friend of mine who's doing this, and I don't know how many places they're even doing this in the state, but he's doing it. And on the way home, I said, you know, I really feel like what I should do now. It was so clean, it was so perfect. And I said, I really feel like I should go home, grill up a couple of ribeyes and put a couple of sticks of butter in between it and make like a sandwich out of these ribeyes with the butter and just eat it just to be, you know, bam, you know. So anyway. You know, there's the two different types. You can do the T1 weighted image or a T2 weighted image. The T1 is going to show up, the fat is going to be brighter. And then for the T2, you know, the fluids appear brighter. Okay, so it just, again, depends on what you're looking for and what you want to bias it towards. It does a really nice job. It can show up changes in tissue, changes in if there's inflammation in the area, if there's extra parts like tumors, you know, whether they're benign or metastatic. I mean, whatever it is, they'll show up there. Okay, now at that moment in time, you don't know what it is. You don't know if it's benign or if it's metastatic tumor, so you have to still go in and do biopsies and do other things, but it just tells you whether something's there. I remember the first, I was in PT school from 83 to 85. I graduated in 85. And this is when, you know, the clinical applications first started rolling out. And, you know, there was only probably 2 or 3 MRs in the whole country. And one of the first things that I remember people making a really big deal about was MS at the time had no way of diagnosing it, you know, objectively. It was purely 100% clinical diagnosis. And for the first time, you know, there was this modality that may be able to start looking at to see if there was, because there was correlation between, you know, plaque in the brain and people who had been diagnosed with the clinical diagnosis of MS. And so really lots of utility for this, and some that we haven't even discovered yet. So because we said we focus on musculoskeletal, one of the things that we really talk a lot about, you know, my background is spine. I'm a spine physical therapist, and that the majority of my clinical practice is related to managing people with spine injuries, not spinal cord, but people with back pain and neck pain. And so one of the things that's really important to us is looking at things like the multifidus muscle. And so here, beautiful, all this area right here is multifidus, okay, on both sides. Big, huge muscle in the low back. And you can see is related to sedentary activities or because of pain. It turns off, it stops being utilized, and it becomes more, this white is fat. And so it becomes infiltrated with fat, and you lose muscle tissue, all right? And so that shows up, you know, on these imaging, okay? And it looks like a ribeye here, okay? And the, what you know, when I was spending some time when I was in my early years, and I was going around, and I told you I met Charlie April, who's a musculoskeletal interventional radiologist, but I was working with other radiologists and physicians in the area. And what I thought was really cool was that Charlie April, whenever he would see this, he always knew it was a big deal. But a lot of the radiologists in the area, when they would see this, I would say, they would just read it as normal. And I would say, well, what about the multifidus? What, you know, aren't you going to say anything about that? And they would say, no, that's normal. We see that in everybody. That's just the way it always looks. And I said, I was shocked by that. But then it made sense because the only people they're taking films of and looking at this is people in pain, right? And so, you know, that's, for them, that's their baseline. That's what they see on a regular basis. But this is not a normal finding. This is a very pathologic finding, okay? Go ahead.
Can you kind of go back to the T1, T2, which I think is kind of what we're talking about here? Why does the fat show up white in one and the fluid? Like, what's the difference? What is it using a different?
It's a flip in the software of how the software varies the image, you know, for the what's picked up by the system. So beyond that, I don't know the scope of the physics behind the why it does that.
Okay.
I apologize.
No, that's okay. I was just curious as to if there was, you know, if we needed to know why you know, is fat denser? Muscle's denser than fat, so I was thinking that the muscle would come up, like that was kind of my thought process, but,
Yeah.
right? Is that right?
That's correct, but you're correct, but it's not, but it doesn't correlate to how it shows up here because
Are you saying it's all
here
how the computer interprets?
I'm sorry.
Sorry, I didn't mean to interrupt you. Are
No,
you
it's
saying
okay.
it's how the computer interprets the image, like to help the way you think?
No,
I don't think it's how the body does it.
And here, it doesn't really matter the density. So like when we talked about the plain films, we were very, the density of the tissue is very, very important. Here, with MRs, it's not the density of the tissue that's important, it's the makeup. It's the histologic makeup of the tissue that's important, that determines whether it's gonna show up like brighter or less bright on the, whether it's T1 or T2.
So when an IMR is ordered, is it specified whether you want a T1 or a T2?
Typically, yes.
Okay.
Sometimes they'll ask for both, and sometimes they'll specifically say, well, I just want a T1 or I just want a T2. Again, depending on what they're looking for. So these are pictures looking at menisci, and you can see the menisci, the anterior pole here, posterior. Here it's, you know, clearly disrupted on the anterior pole. This is a knee joint, anterior, posterior. Same thing, anterior, posterior. ACL ligament here, and then here you can see some disruption. Here's the superior posterior aspect and this anterior inferior aspect, and between the two there's a clear space, so it's demonstrating rupture of the ACL. So again, just more applications for this. Looking at the spine, so vertebral body, disc, vertebral disc, vertebral body into vertebral disc. But see this area here, that's not the same as this one. And what this is showing is that some of the disc, the nucleus pulposus, that gelatinous mass that exists in the disc has unfortunately deviated up through a fracture in the vertebral end plate into the vertebral body. Okay, so this is demonstrating a vertebral end plate fracture. That's what this problem is here. Okay.
Is that like compression?
It could be compression fracture. It could be, that's not a compression fracture, but it could be caused by a compression injury. Okay. A compression fracture what you would see is an actual, like instead of the vertebra looking like this, they would be actually become like trapezoid shape. Here you can see that there's a little bit of a pressure being placed posterior from the disc itself onto the cauda equina. Okay, and here you can see a spondylolisthesis has slippage, probably graded out
probably about 50%, okay, between this segment and this segment.
Okay.
Here's the supraspinatus tendon, and this black space right here is demonstrating a tear of the tendon. This is demonstrating a Hill-Sachs lesion that you'll frequently see with a
anterior-inferior dislocation of the humeral head.
We have a slap tear of the labrum right here. Okay. So new right now is standing MRIs.
So you've seen the open MRI, and the power of the magnet's not as good. So you'd say, well, why don't you always do an open MRI? Well, it's because the results aren't quite as good as a closed MRI. So if you can do a closed, that's better than an open. If because of the claustrophobia somebody can't do the closed, then open is better than nothing at all. And then now introducing the standing MRI, which gives you a better relationship of anatomy, because you think about the anatomy is very, very different looking in terms of our function when you're looking at somebody lying down as compared to being in an erect posture, whether they're sitting or standing. And so it gives you a better appreciation for the true anatomy if you could do it in a sitting or standing position. So that's the value of this. We didn't talk about it during plain films, but there's a lot of times they do plain films in standing, right? Somebody, if they're looking for something like scoliosis, that's done in standing because they want to get a base, from coming from the legs and the feet all the way up. If you have something like a, a tear in the ligament of the Liz Frank tear in the Liz Frank ligament in the foot, you need to look at it in weight bearing. So bless you, you do one non-weight bearing and you look at how the position of the foot, and then you do it in weight bearing and see how the foot, how the relative alignment of the tissue, exists. And that helps to give you the diagnosis, even just with plain films, whether there's a tear there or not, okay? That was the trick that they did prior to MRs. Now they can just stick in an MR and look at it, okay? But if you're, if you're in a rural place or you just want to save money and you don't want to spend money on the MR, then you can do that. You can do those type of things with the plain films.
So lots of advantages. You get really high quality
Imaging of organs and soft tissue throughout the body. You don't provide any ionizing radiation, so it's really, really safe. I mean, you're not doing anything harmful to anybody, and you can use contrast, and that'll potentially increase details for you. The MRs though are really expensive, and they can be time consuming. It might take 30 minutes to an hour. I heard of one person. They did because they had to do a really extensive chest and abdominal, and it took 90 minutes. So they can take a long time to get that done. You got to remain perfectly still, just like we talked about with the plain films. You can see changes in anatomy, but it doesn't tell you necessarily what that change is. Like, so it's not going to differentiate between potentially a pocket of fluid, like related to a a cyst, versus some kind of cancerous tumor. If the person has a implanted metal device, it could cause it to malfunction. So that's obviously, bless you, a contraindication to using that with somebody who has something like that. We talked about people who are claustrophobic, bless you, have a hard time with that. And it's really not portable. I mean, you're locked in. It's built around, the building is built around the MR. And so you're not taking it anywhere, okay? Although they do have the trucks, so you could put it in the back of a truck and take it around town and bring people into the back of the truck. So in that sense, that's as portable as it gets.
You guys doing okay?
Yeah, all right. So now we're going to move into CT. It's again non-invasive, but it's using ionized radiation. It's a plain film on steroids. Okay, so really, really high tech. It's a computer-based plain film imaging, and so you do get lots of ionization. In fact, you get a lot of ionization with CTs. I mean, like double, triple, or more what you get with plain films. So you really need to respect that, okay, with individuals. Really valuable for, has lots of utility for viewing the chest and abdomen, and really, really nice with bony identification of small fractures or fractures that could be hidden, from plain films, okay? Again, just like I talked about with MR, they can do lots of 3D modeling, and so it comes up on your computer screen and you can take an organ. Surgeons are doing CT-assisted surgery now, where they can go and be off-site, and through the CT, they can go in and observe the individual's anatomy, and that helps them work through there. So it's amazing the things that they can do now. This is a fracture of the upper cervical region. This is base of occiput C1, C2. You can see the odontoid coming up here. So this is the posterior arch of, anterior arch of C1. And this fracture would probably not be picked up by plain film imaging. But that's a bad place to have a fracture. Okay, so I jumped ahead of myself a little bit. There's these 3D models and CT assisted procedures that they're doing now, and just amazing stuff. I mean, I first heard about this about 8 years ago, and I'm not a surgeon, so I don't keep up with it necessarily, but I can only imagine where they're at today with what they're doing and how they're doing it. So has anybody had any exposure to any of that stuff out in your clinics? What kind of stuff are they doing that you thought was really cool?
That's the Da Vinci robot. They've already come up with more arms for the robot.
Okay.
I'm not a surgeon too, I'm just a circulator.
Yeah.
But there's a lot more imaging and a lot more there's facial or 3D imaging that the physician could do.
Very cool. Yes, sir.
And I know in spinal surgery, I got to see there's like a striker setup basically where they can do imaging and they calibrate pieces.
Okay.
So that
Yeah.
while they're actually doing the surgery, they can touch it and it shows where they're touching on the image so they can see like if they're in the right place on the spinal body before they tap the screw in. Stuff
Yeah.
like that.
That's sharp. That's really cool. Yeah.
They use Da Vinci, where I came from in the military, a lot with like GYN and neuro
Okay.
procedures, prostatectomies, and
Nice.
GYN stuff.
Wow. It's amazing. So, I just think it's interesting learning about that stuff and seeing how far they can go and where we're going to be in every couple of years, just looking at how far we've progressed with that.
I mean, it's super expensive, but it takes up so much room to,
Yeah.
all the equipment. So you really have to adjust your OR for it. And we just got a second Da Vinci.
Okay.
So you know.
Yeah. Wow. So the CT is pretty fast. It doesn't take as long as the MR. It gives you really high quality views of bones and soft tissues and blood vessels. And again, contrast can be used to help give you a little bit more detail within that. It's lots of ionizing radiation. So again, you really need to be respectful of that. Not as good at soft tissue assessment as MR. Again, not portable. It's very expensive to have the test done. And then, again, not to the limit of MR, but there is the the issue of claustrophobic patients, having challenges with being able to undergo this test. So bone density, we talked about demineralization with osteopenia and osteoporosis with the plain films. So if you have somebody, where they're at that right point in their life and you want to get an assessment, it's not showing up on plain films, but you still want to get an idea, maybe a baseline, for somebody who's, especially the postmenopausal females, and looking at what is their relative bone density. And so this is a method to do that. It's called dual energy X-ray absorptiometry, so DXA, and it literally measures the bone density, and it can help you identify, up to osteopenia, then how bad between the relative continuum of osteopenia up to osteoporosis. So it's again using X-ray technology, plain film imaging, and this is the gold standard for bone mineral density tests. And so it shows up. You see where the where you have high density is that that's good mineralization there. Okay. So you can see here pretty good, here not so much. Okay. Femoral neck, that's looking pretty bad. That's a pathologic fracture getting ready to happen, huh? One misstep and they're done. So it's invasive, no radiation. It's just an expense, and it's really not that expensive. Okay, so it's an easy test, pretty straightforward, pretty quick. Moving into bone scan, I'm going to speed up a little bit just because I still got a lot to cover here. Are you guys familiar with bone scans? It's a nice modality to demonstrate if there's something metabolic going on within a bone. And so, you've done a plain film, you're not sure if there's a fracture or not. You did your CT, again, CT didn't really show anything, but you just have this gut feeling that something's not right. And so you do the bone scan, and if there is a metabolic activity, meaning like a fracture healing, it'll show up as black on this test. And so, things like ankylosing spondylitis. Okay, I think that would be here. This is a demonstration of somebody with ankylosing spondylitis. But look how reactive their vertebrae are. All right, that's indicating that there's a lot of metabolic process. There's always metabolic process going on within the entire connective tissue system, within your bones, ligaments, capsules, cartilage, all of those continuously remodeling. But when you get this, that's telling you, wow, that's a hyperreactive metabolic response, and that's associated typically with either a fracture or a pathologic metabolic reaction of the bone. All right? So those are the things we're looking for. It could be, again, a fracture site, here, hamate fracture, stress fracture of the second toe, ankylosing spondylitis, a tumor, bone tumor, showing up in the femur. Okay, again, just not supposed to be there. Okay. So, non-invasive does a really nice job of demonstrating pathologic changes or excessive reactivity of the bone metabolism. It takes an hour to do these, so it's it can be time consuming. You do expose the patient to ionizing radiation, and there's a contrast, so you always have to be careful whenever you introduce contrast to somebody. Okay, but that's it is what it is. It's not horrible. Ultrasound is a growing modality. More and more people are doing it. Have you guys been exposed clinically to ultrasound? Okay, and so obviously the OBGYNs have been using ultrasound forever, right? In terms of taking a look inside, looking at the babies as they were developing. But now we're starting to utilize that same modality for, assessing other musculoskeletal conditions. We're looking for muscle activation, we're looking for injuries, tendinopathies, we're looking for that we could see the relative quality of the muscle, like the multifidus that I showed you earlier. We can look at the quality of a muscle with this modality. So these are less important, but just so you have this background knowledge, and I'll share this. I think they probably already have it because we've given it in the past, but do you guys have it right now? Okay, so you already have it. Okay, good. So you have this, and you can refer back to these slides in terms of the, how it's working. But here you can see this is the abdomen, and we're looking at the abdominal muscles, and we're looking for how the relative relationship of the internal oblique to the transverse abdominis during activation. What we know is that during a functional activity, in people that have no pain, so just say people with no pain, no back pain, their transverse abdominis always contracts first, and that'll be followed by internal oblique. What's really interesting is that they found that if people who have low back pain, particularly for more than a couple of weeks, it flips and the internal oblique contracts before the transverse abdominis. Well, palpating that, you can't feel that. First of all, it's too quick, and second of all, for the majority of people, there's too much other tissue there to really palpate those well. So with the ultrasound, you really can get a good look and see what's the sequencing of the activation of those two muscles. And so it's really, really helpful, because if you don't know, how do you fix it? So you can look here and see there's a little tear of the patella tendon. Okay, it shows fracture. The ultrasound doesn't penetrate through the bone, so like if I'm doing a ultrasound over the patella, I can see the patella, but I can't see anything underneath it. So that's one of the weaknesses of that. You can't see anything on the other side of a bone. Again, here's the multifidus. Muscle shows up pretty dark, and so the fact that I have so much white inside of these areas, is telling me that I have a lot of fatty infiltrate. Okay, so just think of it's the same picture I was showing you with the MR earlier of the same structure, just another way of looking at it, a lot less expensive. Okay, doing this with an ultrasound as compared to doing it with an MR. So this is what I jumped ahead a little bit. I was telling you about the drawing in maneuver in terms of the contractions, that we want to see the transverse abdominis contract before the internal oblique. Okay, that's just one example of how we could use that. So it's non-invasive, it's really quick, it's easy, it provides information in real time, and it can actually show functional activation of tissues, which is really, really nice. Something that none of the other static modalities are able to do. When you compare it to other other modalities, even just purchasing it, you can get a machine at the low end for the really cheap stuff that's probably not worth it. You can for like $3,000 to $5,000, where you just get the sound head and you plug it into your computer, your laptop with the software, versus getting something a little bit nicer, for maybe $10,000 to $15,000. Okay, so again, relatively, it's not bad to purchase it, compared to a bazillion for an MR, right? And you get really nice resolution. The downside is that it really takes a fair amount of training to get good at knowing what you're seeing and what you're looking for, and not so much the application of how to do it, but to be able to look at the screen, look at the correlation, and see what you're looking for. Is that, what does that mean? Okay. Has anybody seen myelography? Have you heard of it? It's a very infrequently used tool now. There's still a couple of pockets in the US where people are using this, and it's used to identify space-occupying lesions in the spinal cord and spinal canal. So, back in the day, it was used to, it was the primary tool, it was the gold standard for disc pathology. And it's a horrible, horrible test in that, you inject this dye into the spinal canal, okay? And then you invert so the patient's inverted, and then you slowly change their angle, and you watch the dye run through the spinal canal, and you're looking, just like we talked about with the orthogram, you're looking for something to be in the wrong place, or you're looking how the dye traverses through that space. And lots of what you refer to as minor consequences, like people have these really horrible headaches, worst headache they've ever had in their life for 48 hours afterwards, and there's of course the risk for infection, and so it is not a test that's widely used anymore. The MRs and CTs have really replaced it, but there's still pockets of physicians that feel like that's their go-to of wanting to assess for some kind of space occupying lesion, again primarily something like a disc pathology. So again, this is a static picture, so it's not showing you how this would really work, but imagine they're carrying out the procedure and they're looking in real time and seeing, okay, segment by segment, how is this dye, how is this contrast passing along, and is it getting hung up and getting blocked at one specific segment? And that's what they're looking for. So discography and discogram is a modality that's used primarily to assess the quality of the intervertebral disc in the spine. They inject a needle, or they place a needle into the intervertebral disc, and then they inject a dye in there, and then they look, a contrast, and they look to see here's the needle going into the disc, and then what they're looking for is this: how well does it contain the contrast? And so the way the disc is built is there's these lamellae, these rings of the fibrous, the annulus fibrosus, and they should provide some level of containment for the contrast. And so what they're looking for is that dye just running right through those, indicating a tearing of those, and then the diagnosis that's referred to as an internal disc disruption. And so that's before you would ever see anything on like an MR, like you wouldn't see any bulging, you wouldn't see any herniation. But there's still pathology within that disc. Okay. So almost there. So this is an interesting statistic that in asymptomatic persons that are 60 years old or older, 21% are diagnosed with spinal stenosis, through imaging. So they walk in, they get a image, nothing wrong, they're asymptomatic, no pain, no symptoms, nothing, and the radiologist reads it as pathologically they have spinal stenosis. Okay. That 36% are going to be read as having a herniated disc, and greater than 90% are diagnosed with having degenerated or bulging disc. The take home here that I think for us is that when somebody goes in and they have, in this case, low back pain, and they do some kind of image, okay, whether it's MR, CT, they identify that, it could be plain film if they were looking at stenosis, and they identify something. They identify this anatomic change. What do they do automatically? What does the medical practitioner or any of us do automatically commonly? We immediately correlate that patient's pain to that anatomic deviation. What this is telling us is that that's wrong. That's bad medicine. It's bad practice, okay? Because we know that there's a lot of people that are completely 100% asymptomatic that are walking around that have these things. So you have to be really, really careful that you know, the person that's coming in, that's sitting in front of you and has this pain, and then you do this test and it shows up, does it really correlate to that anatomic derangement? And that's got to be your question. And so what should it correlate with? It should be a tripod, okay? There should be 3 components. One is the imaging that we're talking about today. Second one is their subjective complaints, okay? The third thing is the objective measures that we do part of our clinical exam, right? All 3 of those things have to correlate, because if the patient walks in and, so here's spinal stenosis. What's the classic signs of spinal stenosis? As soon as I get up and start walking, it hurts. If I go into the grocery store, it feels better if I get a cart and I lean on the cart, okay? Or if I'm walking and I just sit down, it feels better, okay? And, you know, and typically it's the signs are, you know, pain into their legs, okay? Now you differentiate that with some kind of peripheral vascular disease, right? This is from a differential. But I get that history from the person, okay? And then I do some examination techniques, and I look for correlation to what I know would be show up as spinal stenosis. And then the third part is I look at their imaging. If all 3 of those match, okay, then I can have a fairly high confidence that's really what their diagnosis is. If the patient walks in and they tell a different story than what I just talked about, because spinal stenosis is an easy one. That's one of the classic. I mean, it's so rudimentary to make that diagnosis, okay? But if they come in and they tell a different story, but yet it shows up on imaging, they probably just have a congenitally small spinal canal or intervertebral foramen, okay? And so to give that person a diagnosis of spinal stenosis is a huge mistake. And that would be, you know, that's wrong for a couple of reasons. One is that you really haven't identified what the true problem is. So whatever you're treating, you're not treating the right thing. That's one problem. The other problem is that if that patient gets referred to a surgeon, then what is the surgeon going to do? And I'm not talking bad. I'm not trying to talk negative about anybody, because if you're a hammer, everything's a nail, right? Okay? So surgeons are trying to help people just like we're trying to help people. And if they get a diagnosis come into them that's spinal stenosis, they want to help people, and so their way of helping them is to open them up and give them a little bit more space in there. Okay, that's how they help people. And so don't misunderstand me. I'm not trying to talk bad about anybody. Okay, I'm just saying that's reality. So, but we set this guy up for failure by giving him a bad diagnosis in the first place. So they fixed the spinal stenosis, this congenital anomaly that this patient had, and trust me, you guys know this, that congenital anomalies are the norm. There's no such thing as really regular normal anatomy in human beings, right? So then they fix the spinal stenosis. What happens? He wakes up and he comes out of surgery, and a week later, what does he say? He still has his pain, okay? And he's the lucky one, because nothing bad happened as a result of the procedure. You know, he didn't die under anesthesia, okay? He didn't have any complications with the anesthesia, but you know, he might have complications from the surgery itself, okay? Because it's not an easy surgery, all right? So there are really important critical implications to us not making the right diagnosis with patients. And these are the opportunities where we have really high availability to fail somebody, to fail our patients, because we're jumping to conclusions with poor data. And that's really what, if I could think of one message for us to think about today, is use good data to make your diagnosis, because you're going to be pushing somebody on to the next person. And you guys have lots of credibility, and you're going to be, you know, it's important what you say, because people are going to be taking that and using it to make decisions on, you know, for themselves what they're going to do. So just always use good data and make good decisions. You know, think about, you know, all of the what ifs.
we don't really need to spend a lot of time on this. You guys have this in your thing, but again, it talks about all of the negatives of imaging. And I used the phrase earlier. I said that many of us healthcare practitioners have been seduced by the technology. Okay, that it's just so easy to do a MR on somebody or to order a CT, and we've lost the art of the clinical exam. And I just talked about that. It has to be a tripod. There has to be really good history taking, and then assessment of that history. There has to be, and the history isn't just having somebody fill out a questionnaire and then you read it. There's got to be an interaction. There's got to be follow-up questions and engagement to get some depth out of that. One of the things that's easy for us as PTs is that we spend a lot of time with patients, and a lot of other practitioners might spend 10 minutes at a time, right? But we spend 60 minutes a couple of times a week maybe with a patient. Lots of information comes out during that time, so we get lots and lots of data for us to think about. So that's an advantage for us over other people. And so it puts us in a unique situation where we've learned that engagement, asking the questions, asking the follow-up, don't just take things at face value. Ask the follow-up, ask for more depth, because we know through our practice that it leads us down paths that we would have never gotten to before. Okay, so the first part of the tripod is the subjective history taking. And then the second part is the clinical exam. And how many physicians? What's the average length of physician visits? It depends on the practitioner, right? For family medicine, it's like 7 minutes. For surgeons, it's 2 to 3 minutes. Okay. How do you perform a history and clinical exam in 2 to 3 minutes? I don't know. It takes me. I think I'm pretty good. I've been around for a long time, and I've really spent a lot of time in my life trying to get better. I've been through lots of advanced training and lots of things, and it still takes me 35 minutes to do a good initial assessment on somebody. On a complex spine patient. Okay, I mean, obviously, somebody with a sprained ankle, it takes 5 minutes, right? But I mean, somebody with a complex spine problem, I mean, I'm spending a good 35, 40 minutes with them, just trying to get the basics information from them. And so I don't know how people can do it in 2 or 3 minutes, never mind 7. So anyway, what we know is that when geographically, there's parts of the country where it's actually been traced that diagnostic imaging is used at a greater rate than other places. And guess what's also done at a greater rate than other places? Surgery. So there's a direct correlation between the amount of imaging that's done with the amount of surgery that's done. The more imaging that's done, the more surgery is done. Okay. In places where there's less imaging, there's less surgery. So it's interesting that in some parts of the country, people have less need for surgery than other parts of the country, right? If that's the way you want to spin it. Okay. So I jumped ahead again, sorry. But that's the geographic comparisons. So there are some basic indications for imaging, and I'll leave this with you guys in the handout that you'll have this. We also have the Canadian C-SPI rule, which is a validated algorithm for assessing whether you think somebody needs to even have imaging to begin with. All right, so this is a valuable tool. I mean, particularly, for people working in an ER, this is something that I would, keep on the back of my clipboard, until you, really felt comfortable learning it. So instead of the box, I was able to scan some of these images in there, and so I just wanted to show. I just got some plain films that I want to share with you guys. So how well is that showing up? Can you see? What's the so start through your algorithm. What's the first thing you're going to look at if you're looking at a plain film? Alignment. Good, very good. Alignment. So how's the alignment look there? Relatively, as best you can tell. Pretty good here. Pretty good here. Okay. Density. Looks pretty good. I mean, we'll focus on this upper one. Does everything look structurally and sound and in place? Yeah, so there's a little piece down here. So looks like the tip of the electronon has chipped off. Okay, so that'll be a little fracture of the electronon there. And see, you can see that again too. What is this? Is that a fracture? That's the epiphyseal plates. Good. So we're looking at somebody who's skeletally immature. Okay. Don't know the age, but we just know that their bones haven't fused yet. Okay. This is a moving into the spine. Spinous processes. So vertebra. This is the pedicles. These two bones right here. You'll hear sometimes people refer to them as the owlies. Whenever you're looking at a plain film and you're looking at it, whether it's AP or PA, always look for the owlies, okay? If you ever look at a plain film and there's no pedicles there, that's a bad sign, okay? Because the bony tumors typically start in the, although they're rare, they start in the vertebral body. And the first thing they'll do is they'll chew up the pedicles, and so the pedicles will actually disappear off of the image. Okay, so if you're ever looking at an image and you don't see pedicles, that's a really bad thing. So they're going to need to be referred soon, quickly. All right. So and we have the lateral view. So in the lumbar spine, the lateral view is going to show. Of course, the vertebral body, you're looking at alignment, you're looking at density, you're looking at relative structure, is everything in the right place? You're looking for his spinous processes. You can see the transverse processes coming right at it, right at us. The intervertebral foramen, okay, here, where the spinal nerves are passing out. So at each segment here, here, here. So nice big openings. All right, so that's nice. Versus if you're looking at it and they're really closed down, then you wonder, is that enough space for the spinal nerve to get through there? This is the oblique view. And on the oblique view, the thing that's valuable for the lumbar spine is that you can see the Scotty dog. Okay, you've heard of spondylolisthesis, a fracture of the pars interarticularis. That's where you have the slippage of the spine. So one between the two segments, there's a fracture of that of the pars, which is the portion of the bone that travels between the superior articular facet and the inferior articular facet. And if it happens on both sides, it actually slips forward. And that was one I showed you earlier. There was I think it was a CT or an MR, but it was actually slipping forward. That's what spondylolisthesis is. All right. And so what you're looking for on this, you can see the Scotty dog. So right here, see, here's the Scotty dog. Here's his ears, his head. Here's his body and his legs. Here's a leg. Here's a leg. So you see this whole thing? Doesn't it look like a Scotty dog? I didn't invent this, okay? But, well, if you want it to be a Chihuahua, you can be a Chihuahua. But the thing is, what you're looking for is that the Scotty dog doesn't have a fracture through its neck. Because if they have the spondylolisthesis, what it'll look like is there'll be a fracture, there'll be a space or a defect right here. Okay? So that's what you're looking for on the oblique view. So the way they fix that is with pedicle screws. So they go in with two screws, one screw on each side, straight into the pedicle, and they just attach the segment above that's now that it's fractured, then they reattach the segment above to the segment below with the pedicle screws.
Okay, so it's just 2 screws and drill out the holes and then stick the screws in, and that's it. Okay, that's how they fix that. If it needs fixing, 50% of the people that have this are asymptomatic. They live their whole life and they never even know they had it. So it's not, again, by itself, the diagnosis of this doesn't mean anything. Okay, it's a correlation of, again, it would be one of those common mistakes. Back before 1992, before the ADA came out, if people were found to have that on a plain film image, they were removed from doing certain jobs. And when the ADA came out, that was banned. That was one of the things that they stopped doing, because there was enough data demonstrating that, look, people can have this and live good, healthy lives and do labor jobs and do all kinds of things, and it's not a problem. All right. So just because you see that, it doesn't mean that's what the cause of their pain is. It has to correlate with everything else. So these are just different views. This is the oblique view, and then the AP. This is a specific lumbosacral shot. The lumbosacral junction is the area of the lumbar spine that has the highest amount of pathology at it. So it's frequent. People will ask for imaging. They'll ask for a lumbar series, and they'll ask for a specific lumbosacral shot, just to get really specific within that segment. So I think I have 2 of those. That's a little bit cleaner and shows the anatomy here. Okay. So you can see how the sacrum is tilted. And it's interesting in people, I mean, the sacrum has a lot of variation with the tilt. I mean, some people it's more vertical, and in some people it's more horizontal. Okay? There's some people you look at it and you think, man, I could put my coffee cup on the back of that thing. You know? I mean, that's literally how horizontal it is. And the more horizontal, the more stress it's placing at this segment right here. Okay? So now moving into the cervical spine. Again, PA view is looking for spinous processes, pedicles. This is a bad shot. I'm sorry. It didn't come out very good when I moved it to this. Ugh, these are horrible. I'm sorry. This is the lateral view. This is, I think, was supposed to be the oblique view, and the difference in the lumbar spine, I talked about the intervertebral foramen, and you see that on the lateral view. In the cervical spine, you see the intervertebral foramen on the oblique view. So that's a difference between the 2 regions of the spine. All right. So you can see barely, but you can see here, here, a little bit here, the intervertebral foramen, because it's an oblique view of the cervical, versus this is a lateral view. And again, we're looking for alignment. We're looking for anterior alignment, posterior, all the way down of all of those structures. Assuming this is normal, because it is, this would be a abnormal. See, it's a flattening instead of having that nice C curve in there. That's healthy, what it should look like. This is a flat, straight cervical spine, so that would be an abnormal position. By itself, really doesn't mean very much, other than they have an abnormal posture. Okay. This is the what we call dynamic films. So we take somebody in neutral, and then we take them in full extension, and then we take them in full flexion, and we're just looking for, does that change the relative relationship of the bone? Because if we would expect everything to move a certain way, and so I'm looking and the spaces are still good, everything's fine, anterior, posteriorly. If I looked and the spacing, say between C1 and C2, was not what I would expect it to be, what its relative norm, then I have to start thinking, there might be a fracture or a ligament rupture that's present there. And so that's what these tests are trying to tell me. So I'm looking at them in both extension, and then I'm going to look at them in flexion. So again, I'm looking at the relative relationships here of spacing and spacing between spinous processes. And I know what the norms are, so I'm just comparing what I'm seeing on the film compared to my norms. This is an open mouth view, so what we see here is the lateral aspects of C1 here and here. This is C2 with the odontoid. And so again, we're looking for a relationship between odontoid process and the C1 lateral masses. And if you see deviation, significant deviation on one side or the other, then you start being curious if there's an alar ligament rupture, which would be a big deal. Okay. So questions? Oops, I think I borrowed some time there. I'm sorry. Well, thank you very, very much. I really do. Again, I always value the time to spend with you guys, and I appreciate the opportunity to come and talk about this stuff. And I love the questions and the discussion, and I hope that it assists you in some way to within your practices to do something good for patients. So anyway, thank you.